السلام عليكم.
وعليكم السلام ورحمة.
كيف حالك دكتور؟ تمام؟
الحمد لله بخير. كيف صحتكم؟ إن شاء الله كلكم طيبين.
الحمد لله الحمد لله. How's everyone?
Everybody's doing good so far. So, assalamu alaikum everyone. Today we're gonna start the Zoom meeting for our weekly Zoom meeting, inshallah. And then the team will start, the red team. Sulafa, if you want to lead the meeting, that would be great. Thank you.
Thank you. Assalamu alaikum everyone. I'm going to host today's meeting on behalf of the red team. We have 4 topics to present: geriatric syndromes, malaria vaccine, mock interview, and the fishbone diagram. We're gonna start with malaria vaccine with Dr. Mutasim, if you are ready.
Yes, assalamu alaikum everybody.
Alaikum assalam wa rahmatullahi wa barakatuh.
Let me share my screen first.
Sure.
Yes, go ahead.
Do you able to see my screen?
Yes.
So, hello everybody. My name is Mutasim. I'm going to present a malaria vaccine. The topic is kind of like complex and it's have a lot of new things coming up. So I try my best to do whatever I find in the website, and most of this is a study. So I try to give a brief about it's most commonly vaccine used. And before I start that, I would like to give you a slow reminder about malaria and how the malaria affect the population. Malaria, it's a leading cause worldwide, and it's affected around 100 countries in the world, mostly in tropic and subtropic area. And recently, between 2019 and 2020, the malaria, the cases increased by 6% from the usual, and the deaths also increased by 12%. And unfortunately, things that most of the deaths in a vulnerable population. It's mostly children with less than 5 years. This is mostly died population from malaria. Excuse me, can I drink some more? Sorry. So this is the most affected population. Malaria, as everybody knows, it's a vector-borne disease, mostly transmitted by Anopheles mosquitoes, the female one. And it has many species. The most common species is Plasmodium falciparum, which is the most severe one. And the other one is Vivax, it's kind of like a little bit. And the other 2 one is Ovel and Malaria. The one thing that makes malaria vaccine, it's kind of like difficult. Every one of these parasites have its own morphological, biological, and pathological, and even clinical presentation. And also they have a complex life cycle in the human being and the mosquito. And even in the human being, they have a liver stage and blood stage, which make it's kind of like difficult to target it. It presents in a different way, but it's kind of like a mild disease for someone who lives in endemic area, and it's not severe for someone also live in endemic area or for the first time you get the malaria. And the fever of the malaria, it's have a different type, so it's make it to classify malaria according to the fever presentation. This is the life cycle of malaria. the usually infected stage is sporozoites from mosquito get into the human blood and then went to the liver. From the liver it forms schizont, and from schizont it forms rupture, it forms sporozoid. Sporozoid it enters the RBC, it forms another schizont until the RBC is rupture. This is when the symptoms start. And there is some group of the schizont, they went to form a sexual stage for malaria gametocyte, which is to be ready to become by mosquito for the completion of the cycle. So diagnosis of malaria, it's a proper history examination, also routine investigation looking for differential diagnosis and complication of malaria like anemia and other thrombocytopenia. Also a specific workup for malaria by blood test, and also we're doing a molecular test to assess to diagnose malaria. And even sometimes we went to do we're going to do bone marrow biopsy for assessment. Management of malaria, it's the prompt management for malaria is started by early detection and treatment. When you detect malaria early and treat it early, it's kind of like have a little complication. But when you have a delay in detect malaria, it's make it more difficult to treat. And every stage of malaria, they have certain treatments, and this is adjusted by the local or international guideline for treatment. So. Prevention. Prevention by chemoprophylaxis. This is for one profiling to endemic area, or sometimes used. The initial prevention was used in India at that time. In 1986, was by chemoprophylaxis also. The other one is vector control measure, by vector eradication with anti-larval measures or anti-adult measures, and also by using mosquito bait or all cream that prevents from biting by malaria. The other is vector vaccine, which is have a certain limitation. And the other, our topic today is human vaccine. The idea for human vaccine is developed from theoretical concept that mostly the woman passes antibody against malaria to her newborn child. And the other one that if you live in an endemic area, the effect of malaria on the disease, it's kind of like mild, like common cold, or sometimes got unnoticed. Hello?
Yes, we can hear you, Dr. Mutasim.
Yes. Can stop me if you need if I'm going so fast. So the ideal malaria vaccine, it should be composed of three. It's prevent infection, also reducing clinical disease severity, and reduces transmission. So if you have a vaccine that's have all these characteristics, kind of like be an ideal malaria vaccine. But mostly all the vaccine available outside is just have one like reducing transmission and have some effect in clinical disease. And the other one is prevent infection, but it doesn't reduce the clinical disease severity or reduce infection or reduce transmission. Sorry. A type of vaccine, it classified according to which life cycle of the malaria it's targeting, the pre-restorative vaccine. This type is produce antibody against sporozoid. And so it's delaying on liver invasion or multiplication. So it's an ideal vaccine for someone who's traveling to endemic area. Asexual erythrocytic stage, which is form antibody against merozoid. And also targeting antibody targeting malaria antigen in the RBCs. So it's reduced clinical severity of malaria. The other one is sexual stage vaccine, which is prevent the development of infectious sporozoid. This is kind of like vector vaccine, the sexual stage. So this is the classification of malaria vaccine. It's kind of like giving some type, like the pre-restorative stage. The most common vaccine targeting antibody is circumsporozoid protein, and the liver stage antigen also. The merozoid, and this asexual stage erythrocytic binding antigen, like merozoid surface antigen 1 and 2. Also, the other one is apical membrane antigen. The gametocyte inside the human body, this is an sexual stage inside the human body, like PFS T5, and the other one is PFS 200 series. The combined vaccine, which is SPF66, based on pre-restorative, it's have a two-stage pre-restorative and sexual blood stage protein. we'll discuss some type of this vaccine like SP5 and Matrix, and also we're going to discuss the RD21, R21. This did give you clue about they have many study for each vaccine, and this picture is taken around 2019. Like inhibition of morozoid, the first one, they have one in stage 1A and P, and they have the last one is in stage 2A of trial. It's the other one, like killing the affected hepatocyte. I think the most advanced one is stage 2A, which is CHADOX 1 MV1 vaccine. And we have the most recent one here inhibits porozoid infection, which is a periuretic stage, like the R21 matrix M phase, which is reaches stage phase 3 in most of in recent study. And the other one, it's RTS-AS01. It's have a pilot implementation after stage 2 and went to stage 3, but they have a certain limitation, so they stopped at stage 3. So the first national eradication program was held in India in 1953 by using chemoprophylaxis, as I told earlier. For many years, WHO is struggling to find a highly cost-effective vaccine to be used with other measures to prevent malaria. In the past, the only right vaccine was RTSS, or the other name is called Mosquirix. But they have a problem. They offer just a partial protection in endemic area, and it went out within 1 year. After 4 years of study, they find the efficacy dropped by 35 to 35. The problem affecting vaccine development for malaria, firstly, the evaluation of how vaccine effective, and the other thing is how the parasite indigenous way. The parasites is kind of like they have a lot of way to avoid immune response whenever they have antigenic variation, and they have a lot of point mutation within it. And the other thing, it's complexity of conducting a clinical and trial field for the malaria. Antigenic variation is one of the defense mechanism of malaria parasites, especially Plasmodium falciparum. It can do antigenic variation. It's doing mutation in 2 types: in sexual stage and asexual stage. In sexual stage, by recombine the gene, and in the asexual stage by point mutation during the replication of parasite. We will discuss 3 types of commonly used vaccine, and they have an advanced trial on it. The first one is SPF66. Is the first vaccine developed and undergo clinical and field trial. There is many vaccine, but this is the first one that undergo clinical, field trial also. And the other one is just animal, and till now most of them didn't reach to be used in population widely. And it's a combination of antigen of sporozoid and merozoid parasite. It mainly targets an asexual stage. And it held in 10 trials in Africa and Asia and South America. Initially, the result was promising, but for many years, it's shown there is no effect in African population. Also, there's a problem in how can cover a long-term immunity. So for that, they stopped using it as the model vaccine for malaria. The other one is RTS malaria vaccine, which is a periuretic stage. It combines sequences of CBP protein and hepatitis B surface antigen adjuvant to AS01 and AS02. The AS0 type of this vaccine, it's the one that was used widely, and it's have a partial efficacy. They induce antibody against highly conserved part of DNA. It's called NANP, and it has been used in sub-Saharan countries between 20 to 2013, and its efficacy was dropped by 36 after 2 years of study. And the other new vaccine was RT21 Matrix M. It's in phase 3 of study. It's Geriatric. It's same like the first one, like this one. It's same in composition of CS protein and hepatitis B surface antigen and adjuvant without adjuvant SO01 and SO2. So it's held initially in Burkina Faso, and so it's have a good result within 1 year for efficacy and immunity. And after that, they held it in another country like Mali, Kenya, and Tanzania. And this and the other research was it's multi-center research that's done by University of Oxford. And after showing the promising result in more than 70 or in some research 75, they increase the dose of the adjuvant type matrix, and the result is increased to 80% in children. So after that, the WHO is discussing applying it as a board using of vaccine for sub-Saharan Africa. And this is the result of the last one that published recently about this study. It's multi-center trial showing its efficacy and have high efficacy and immunity against malaria parasite. And it is done as a double-blind studies in around 240 child. They one of them took the vaccine, another one took the rabies vaccine, and it showed promising results. But the problem is it's using after one using the booster dose after the seasonal malaria, like after the April. So they didn't know exactly its effective vaccine or because of seasonal malaria. And the initial dose was 3 doses, was given in a 4-week apart. Every month they give a dose for the child. And some study also in some area other than Burkina Faso, they give a 4 dose of vaccine. And the result is shown in most of the area. It's maintain efficacy by 75% in 2 years follow-up for this population. But as I told you, most of the researchers, they see it's a lot of answer need to be a lot of questions need to be answered for this vaccine, like vaccinate, how can give it to the child, and they need to be involved in the ABE and the booster timing dose every year, or and also how to measure the efficacy of this vaccine, and how to apply the policy of this vaccine in between WHO and the regulator, African regulator policy for this vaccine. So I know it's kind of like a difficult topic, but I try my best. If anyone have a question. Hello.
I don't think there's a question. Drop down chat. Thank you so much, Dr. Mutasim. The next topic is going to be geriatric syndrome, presented by Dr. Amna and Dr. Ashwini. Dr. Amna, if you are ready, you can start.
Assalamu alaikum.
Alaikum.
Just a second to share my screen. I'm not able to share my screen.
do you see that green color share screen at the bottom?
Yeah, but
Not working?
if I make share, they didn't allow me to share. They cancel my screen.
Okay. Can I share? Do you want me to share?
Yeah, please, if you can. Thank you so
Okay,
much,
sure.
Dr.
Sure.
Ashwini. Mm.
Just give me a minute, please.
Mhm.
Just give me a minute. I'll share. Okay.
I think I can make it, Dr. Ashwini. Yeah.
Yeah, can you see?
You see my screen now? Everyone?
I think
Or you
Amna, that's my screen. Yeah. Did you get your screen?
Okay, let me go down. You can close, Dr. Ashwani. I think I get.
All right.
Yeah.
Yeah, you cannot share at the same time.
Yeah. Now you see my screen? Or not yet?
Can't see anything.
Okay. Okay, Dr. Ashwani, please. Make it for me.
Okay, sure.
I will try to make it easy for you.
Amna, I started sharing. Can you all see my screen?
Yes.
Yeah.
Okay, Amna, please continue.
Amna, are you there?
Hello.
Go ahead,
Yes,
Amna.
is it Amna? Yeah.
Yes, we can hear you, Amna.
Yeah, I found myself out. So I'm gonna talk about geriatric assessment. Our objective is to describe comprehensive geriatric assessment and importance of geriatric care, and to discuss the component of assessment through the case studies, and to review common geriatric syndrome, including diagnosis and management. Next, please. So why geriatrician and why geriatric and who need geriatrician? Because if you are lucky, you will do it. As the healthcare professional, you practice and you have to practice and you have to be like familiar and you have low threshold to detect the problem and improve their health. As a young person, you have to respect it. As a contributor and a family member of the community, you want to make a difference and improve their quality of health. We see here that the number of geriatricians in the United States is increased and expected to be increased more and more in the upcoming years. Next. The geriatrician is a cornerstone of geriatric medicine. and they make it about multidisciplinary team, and the patient and family appreciate their approach to the patient care, and all about the patient care to be done in good manner. Next. Dr. Ashwini. Yeah.
I changed the slide, Amna. You can't see.
Now everyone see or just me?
Ashwini, maybe you can proceed to the next slide.
Okay, now.
Yeah. Yes, perfect. So the geriatric team is component of geriatrician, geriatric nurse practitioner, social worker, clinical nurse, case manager or nurse practitioner, therapist, and other geriatric specialists. So the assessment, we go through the screening to screen the patient for depression. We do geriatric depression scale and screen for cognition. It's include like many mental state examination and slums, mini cog. The other assessment, we do financial functional status like activity of daily living and instrumental activity of daily living, how they deal with absence. Mobility status, it include get up and go test. We talk a lot about this test before. Nutrition assessment, by many nutrition assessment to see if the patient is malnourished or at risk of malnutrition. Medication review, and the comprehensive history and physical examination. So this is slum examination. I'm gonna go over it quickly. Before, you have to mention the patient name and the age, and the level of education is important because you grade the patient according to like if he is high school graduate or under high school graduate. So the first 3-1 is talking about orientation. You ask the patient how the day of the week is it, and the year, and like what state we are in. And the question number 4 is like word list. We give the patient about 5 words and tell him to tell you back these 5 objects. If he miss one, you tell him and let him he or she to tell you back. The question number 5 is like mathematical question. Simple math question. I'm sorry for that because the screen is not like obvious, but on my slide I fixed that, but I'm not able to share. So and the question number 5, as we say, we do simple math and give the patient slow time because it's like he have to make it in his mind without calculator. And the question number 6, we allow the patient to name how to you will tell him to tell you about animals in 1 minute, and we give him like they have, if he mentioned from 0 to 4 animals, 5 to 9 animals, or more than 15 animals, and you score that. And the question number 7, we word recall. You tell him to tell you back that the word you tell him before, the 5 object. In the question number 8 is number span. like you tell him that you have the number 42 and he have to make it in order. So he tell you it's 24. The question number 9 is ask the patient to draw a clock. Yeah, and they mention the time is like 10 minutes and 11 o'clock. At least he have to make the 4 anchor number like 12, 3, 6, 9. And the question number 10 is 2-step. It let him do X in the triangle and ask him which figure is largest. And the question number 11 is a story recall. You tell him small story and then ask the question related to that story. And the total score is Dr. Ashwini. Yeah, go back, please. The score is yeah, the total score, like, I don't know why is not appear, but according to that, yeah, we have like a minimal, or he have like minimal cognitive impairment, or he has dementia, and the scores depend on the degree of education. So yeah, can go next. The functional status, like classify the patient as independent, or he need assistance, or totally dependent. About daily activity level, like bathing, dressing, is like personal hygiene, toileting, transfer, continence, and feeding. Instrumental activity level, like how he use telephone, traveling, shopping, who prepares a meal and who cook for him, for housework and laundry, medication, and how he deal with bills and money. Go next. So get up and go test to assess mobility. Like you say to the patient, sit comfortably at a straight back chair, and then he rise from the chair and go for short distance and turn around and then come back. And we scale from 1 to 5. 1 is normal and 5 is severely abnormal. And if the patient scores 3 or more, he have risk of falling. Next. Nutritional status, like we classify the patient at if he normal, or he have malnutrition or risk of malnutrition, and just you ask the patient how you prepare your food, and who take care of that, and be aware of the cost and ill-fit indenture, because it's a problem for elderly, and the presentation of food and social isolation. Next, medication review. You review for the patient prescribe and over-the-counter medication, because we know that a lot of medication, they have side effects, especially for elderly patient. Drug-drug interaction, and safety in elderly regimen, how he take his medication, and how he or she organize her medication. Next. So traditional use of geriatric assessment, we have to know that is primary care geriatrician is not only for consultation. He have a primary care, and we evaluate the need of long-term care, of transition of care. And you can go next, please. And the assessment is show that they have successful outcome in improving function, allow patient to remain at home, and decrease hospital readmission and complication of hospitalization. And it is like a good tool in assessing in geriatric patient, and can be applied in multiple settings. We go through scenario. and how they conduct the assessment. The first cancer patient is Mrs. T.L. She is 48-year-old female, American female with history of depression, moderate Alzheimer's disease, hypertension, diabetes mellitus, and hyperlipidemia. Present to clinic in July 2004 to establish care, and the assessment is depression scale. She grade 8/15, and mini status examination she grade 18/30. She is dependent for bathing and instrumental of daily activity, independent for shopping, transportation, finances, and housekeeping and laundry. And the examination for get up and go was normal. And the basic lab was done, liver enzyme. Physical examination was normal. In 2 months later, the patient daughter called and he said that her mom has turned yellow. The patient seen next business days for workup include imaging and lab, and she was found to have pancreatic mass with obstruction and biopsy consistent with pancreatic cancer, and the biliary stent was placed. So they arranged a family meeting, and the finding was presented and recommendation is made. Recommended for hospice care for symptom management and end of life care with geriatrician. The surgery team recommends surgical resection and refer patient to oncology. And the oncology recommended chemotherapy and more aggressive treatment. But the patient and the family agreed to do only hospice and comfort care. And the patient has wonderful Thanksgiving holiday surrounded by family. And unfortunately, he passed away the next day. So, yeah, here we're gonna talk about ECOG. It's like we make this scale to performance status to describe that the level of functioning in terms of how to improve improve survival and to allow prognosis for mortality and mortality. Grade 0 is fully active, that he can do all his performance. Grade 1 is restricted in physical strenuous activity. In grade number 2, he is like capable of self-care but not able to work. Grade 3 is capable of only limited self-care, confined of the chair in more than 50% of working hour. Grade 4, he the patient is totally confined to bed or chair. And grade 5 is dead. And this is colonoscopy scale. This we grade the patient from is not ECOG, is colonoscopy. That we make functional status. We scale from 0 to 100, and we classify a patient according to that if he can do his work or dependent for other. So next, please. So here, as a continue, that use of geriatric assessment can further enhance the information obtained or interpreted from colonoscopy or ECOG scale. Is predict survival, chemotoxicity, and post-operation mortality and morbidity we said before. Next. So this is another scenario. We have the case of Mrs. PH. She is 8-year-old female admitted to general surgery team, and the reason for consultation is delirium. Her past medical history is she had diabetes, hypertension, coronary artery disease, myocardial infarction, and coronary artery bypass graft, congestive heart failure, breast cancer, depression, osteoporosis. The patient was noted to have left breast cancer, left breast mass found in September 2008 and was referred to oncology. The patient is enrolled. She take tisagenib, and 1 week after initiation of therapy, patient has myocardial infarction and coronary artery bypass graft performed. Daughter attributed chemotherapy, attributed the chemotherapy to MI and decided to pursue with no further chemotherapy. The patient received care of other side, and after a year, she presented to hospital oncology with 7x7 inflammatory lesion with central nipple ulceration and blood discharge. The patient was referred to general surgery clinic for palliative modified radical mastectomy with split thickness skin graft to be performed. Her daughter decided for her no chemotherapy, and her oncologist said he have no option. The patient seen by cardiology for clearance and for geriatrics for clearance, and the assessment is go like the scale of depression 2/15 and status examination. She is unable to complete because she had a visual impairment. She is dependent for bathing only. And instrumental of daily activity is dependent for preparing food, taking medication, finances, laundry, and housekeeping. Get up and normal was abnormal because she is adherent to wheelchair. And patient deemed intermediate surgical risk. So the patient underwent MRM with a split thickness and admitted to general surgery team. And cardiology was consulted to manage her blood pressure. On hospital day 2, geriatrics was consulted to evaluation of delirium. So the assessment, they unable to make the MMSE and depression scale because of delirium. And memorial delirium assessment 23/30, and activity of daily living. Some assessor requires dependent for all instrumental daily activities, and family supported by her daughter. Can you go back? Go back, please, Dr. Ashwini. I'm sorry. Yeah. So the patient was diagnosed with mixed type delirium and started in haloperidol. Geriatric assumed primary care when her surgical issue was stable. Patient delirium was resolved and the patient transferred to neighboring hospital. This showed that the breast cancer incidence and mortality, both of them increased by increasing age. You can continue from here, Dr. Ashwini.
Thank you so much, Amna. It was a great presentation. I'm sorry for those two errors.
No, thank you so much.
You're very welcome. All right. So we have something called as PACE. What's PACE? PACE is a pre-operative assessment of cancer in the elderly. Pre-operative assessment of cancer. So it was a pilot study established in 2003 in supportive cancer therapy. What were the instruments? We know mini-mental status examination, assisted daily living score, IADLS score, GDS, brief fatigue inventory, ECOG performance status, which Amna went over, American Society of Anesthesiologists physical status scale, and Satoriano's index of comorbidities. So this helps pre-operatively for an assessment of elderly. Having one dependent IADL, abnormal presenting symptoms or moderate severe blood flow index increase the patient's likelihood to have any surgical complication by 50%. If you look here, the type of complications, the major complications are in dark blue and any complication are in lighter blue. So the complex major up to 80%, 70 to 80%, if you can see, we have a percentage with complication, 30% almost end up with complication, especially the major as well as any other complication. Now, if you look at the age group from 70 to 80, who have moderate or intermittent, the major complications are almost zero, but other complications are up to 20%. Now, if you look at the age group of 70 to 80 with major scenarios, the complications are again up to 5%, the major complications, but we do have other complications up to 50%. CGA and the surgical patient. This patient had a major surgery with subsequent complications and a very difficult post-operative course. Follow-up visits with the patient in the palliative clinic determined that her delirium did resolve eventually and the patient was bed-bound and completely dependent of the care. She was ultimately placed on home hospice. So CGA and the vulnerable patient. Investigating cases of suspected elderly abuse can be a daunting task for all involved, right? We don't want to say that an elderly has been abused. It's not good for us. It's not good for the patient, nor for the family members. So it requires a multidisciplinary approach to the patient, including local adult protective service authorities, the judicial system, and the geriatric team. The work of medical case management team generally occurs in 3 phases. Very first, you're going to investigate or assess made by the referring agency. It can be anybody who is going to refer. Secondly, you will have a comprehensive geriatric assessment done by the medical team led by the geriatrician. I cannot see here. Sorry, I couldn't see. The third thing that we are going to do is interprofessional team meeting to develop a joint intervention plan. So okay. Now we are going to assess via a table. So what evaluation are we going to do? We are going to assess the cognitive function using a Falstein mini mental status examination and discipline involved by SW, GNP, and MDs. Depression screen, geriatric depression scale, again SW, GNP, and the MDs. Assessment of the activity of daily living, SW, NCM. Assessment of instrumental activities of daily living by SW and NCM. Medication review by the pharmacist. Comprehensive history and physical examination by the GNP, MD. They can evaluate via the physical exam. Home visit when indicated. Who is going to do? A case worker, SW, APS, NCM, GNP, or an MD. Interdisciplinary team meeting, APS, SW, NCM, GNP, MD. So who is SW? Is a social worker. GNP is geriatric nurse practitioner. MD, we all know, is a medical doctor. NCM, nurse care manager, and APS is a case worker. CGA and hospitalized patients. So this is used in acute care of the elderly units. provided as a part of geriatric consult. No study is worth more value than the appreciation from other disciplines. The kind words from families and the joy on a patient's face seen when you say, I am trained to take care of you and your friends. Of course, that builds the relationship. Now, about polypharmacy, it's defined as a greater than 4 prescription medication or greater than 3 new medication in 24-hour period. 4 or more prescription medications increases the risk of falls in the elderly, which is very important to as a preventative management. 5 or more prescription medication increases the risk of adverse drug reactions. 30% of older adult hospital admissions can be linked to drug-related effects. Polypharmacy is the 5th leading cause of death for hospitalized elders. Right, that's why we need to be careful with especially with anticholinergics, adding them with the antihistamines. It's going to cause adverse effect, especially the fall. Aging and medication metabolism. So liver is the main organ and it declines in about cytochrome P450 system as we age. The excretion through renal, we know the GFR decreases as we age, resulting in decreased tubular function, decreased creatinine clearance. Because the creatinine clearance is decreased, there is an increased serum level and increased plasma half-life. What are the polypharmacy signs and symptoms? Dry mouth, mostly anticholinergic, dry mouth, tachycardia, confusion, diarrhea, constipation, peripheral edema, extrapyramidal side effects, syncope, orthostatic hypotension, hypoglycemia, congestive heart failure or pulmonary edema because decreased heart rate, flatulence, bloating, somnolence, and lethargy. So you need to be really aware of these symptoms to recognize polypharmacy in a patient, even constipation or diarrhea, simple confusion also we need to keep in mind. Factors associated with polypharmacy. Patient factors and system factors. What are the patient factors? Older age, female, low education level, rural living, multiple chronic illness, use of multiple medications, and having multiple pharmacies dispense medication. Going to the system factors, there are many different prescribers. So as you age old, we know we have a primary care physician. Maybe the patient will have a consultation with a cardiologist. He prescribes some medications. The patient has some stomach issues, so he goes to gastroenterologist who prescribes him more medicines. He has rheumatic issues, goes to a rheumatologist, gets more polypharmacy. So we have varied level of prescribers in this particular age group, which may lead to polypharmacy. Poor patient record keeping. As I've been working, I've realized that there has been discrepancy between the communication because there are many people involved, many levels of communication. So that can result in poor record keeping of the patient. Failure to review patients' medications at regular interval and post-hospitalization. So this post-hospitalization comes in known as a transition of care. As they are released from the hospital, the primary care provider has to be able to recognize the polypharmacy and go on with advising the patient. So that's the best transition of care. Okay, so now we have some principles for prescribing for older adults. So we need to know, is the medication really necessary for the patient? When you look at the medication list, half of them probably could be just, taken out of their list. Do the benefits outweigh the risk? What are the desired therapeutic effects and how will they be measured? What are the potential drug-drug interactions, which is very important? Try to start only one new medication at a time, not all together. Titrate the dose slowly as tolerated by the patient. Start with a low dose and then we can increase. Identify and explain the indication and the directions to the patient and the caregiver, which will help in, the continuity of care and them taking the medication. Identify and stop any duplicate medications. Okay, now how do we manage the polypharmacy? We can manage them pharmacologically and non-pharmacologically. Pharmacologically, what can we do? We can review the medication at every office visit, after every hospitalization. Eliminate medications with duplicate effects like anticholinergics and antihistamines. Stop medication that are ineffective or have suboptimal therapeutic effects, like it's not advantageous to the patient, you can just stop the medicine. Add new medications one at a time. Use the advice, start low and go slow for starting new medications. No all non-prescription medications. Now, how do we do the non-pharmacological way? Write out schedules to the patient cleanly. Morning, you need to take this medicine. Afternoon, you need to take this. And at night time, these are the medications. When you write out the schedules, you will get better efficacy in patient's management. Write out the indication for each medication. When you educate the patient, the response gets better, as we all know. Use pill boxes to track the adherence. Very nice suggestion. Detailed explanation of each medication and the indication increases the adherence. So what are we trying to achieve here? We are trying to achieve adherence to the medication and review the medication which are not helpful. Just get rid of them and make the patient adhere and better outcome. Comprehensive history and physical exam. History taking under older patients. So we have to take the vitals as soon as any patient comes in. That will help us in identifying orthostasis. Listen to the patient and the caregivers who are going to tell you the signs and symptoms, which we went over in some of the earlier slides, and do a physical exam. Older patients tend to overestimate their health or underreport their symptoms accidentally or so in older age it's very common to have constipation or diarrhea, right? So which was one of the symptom in polypharmacy. So they may not be able to say what we need to do. We need to listen to the patient and caregivers very carefully to understand the situation. Consider most of their symptoms as normal aging. Embarrassed or see symptoms as loss of virility or power as they age, or they simply forget. Now, history taking in the older patient. We have to take history of present illness. Pain is the most common symptom as experienced in the older population. The mnemonic that we can use is coldest, which says acute versus persistent. Persistent means ongoing for a longer time, which helps us differentiate to treat. C is for character, O is for onset, L is for location, duration, exacerbating factors, strength, and timing. So you need to know the character. Is it a dull pain? Is it a sharp pain? Onset, were you doing something that the pain started, or did it start while you were sleeping? So the onset is important. Location, is it a pinpoint location, or is it spread most of the time over the abdomen? Duration, exacerbating factors. If you bend forward, does it exacerbate? Or anything, if you eat, does the pain increase? And the strength of the pain, timing of the pain. As soon as you eat, does it increase? If you go to bed, does it relieve? So the timing is important. Other comorbidities like diabetes, hypertension, does it fit with other geriatric syndromes? So we need to take a careful history. Continuing with the history taking, what is geriatric syndromes? Dementia is one of it. And how are you going to ask the patient? You're going to ask, do you feel like you have a problem with memory? Delirium, have you noticed a sudden change in your behavior or confusion? Falls, have you had any falls recently, or do you fall frequently? Urinary incontinence. Are you able to make it to the bathroom without any accidents? Right? If they do so, then it becomes urge incontinence. Depression. Are you depressed? Malnutrition. How's your appetite? Do you feel hungry? How do you get your meals every day? Is somebody giving you? Are you in a nursing home? Somebody else cooking for you? Are you in a toast or tea diet? Insomnia. Do you have difficulty with sleeping? So these are very important questions when you're taking history to identify the geriatric syndrome. Depression. Why are older people so sad? Maybe because they're out of job now, the family does not support, they may be alone, they don't have a family support, which is a main reason. Prevalence of depression. In our community, 2% have major depression, 10 to 30% have depressive symptoms. In an outpatient setting, if you see the patients, 5 to 10% have major and 10 to 30% have depressive symptoms. In an hospital, inpatient setting, 10 to 20% have major depression, 10 to 30% have depressive symptoms. Long-term care setting, in a nursing home or any other place, 10% have major depression, which is a really big number. They have major depression, and 30% almost have depressive symptoms. So as you see here, long-term care setting means without a family support, the depressive symptoms are more than the community ones. Isn't it an outpatient issue? Why screen in the hospital? That's a question. Up to 1/2 of all depressed elderly seen by a primary care physician are not identified as depressed. So depressive symptoms in hospitalized elders can increase the risk of readmission, functional decline, and mortality. So what about depression in the hospitalized patients and why we need to screen them? Because that can increase the length of stay because it slows recovery and mobilization. Inpatient is a good time to make a diagnosis and get referral in place because it's easy to reach a psychotherapist there, and treatments are effective. Who is at risk for depression? Female gender, divorced or separated status, low socioeconomic status, poor social support, comorbid illness, cognitive impairment, adverse or stressful life events, family history, prior depressive episode, prior suicidal attempts, or financial stress. So adverse stressful event can be even if a patient had a recent myocardial infarction, they are at high risk of getting a depressive episode. Okay, so associated medical problems. Dementia is a major problem. Diabetes mellitus, rheumatoid arthritis, history of cerebrovascular accidents, myocardial infarction, cancer. Very important. Parkinson's disease, all of them cause addition to depression. Now, what are atypical presentation, which is not a typical presentation of CG caps that we know? Atypical is older patients depressed often have different complaints and presentation than younger patients. They less commonly experience the mood symptoms. Older patients often have more somatic symptoms and may end up hospitalized, like stomach pain, arm pain, something like that. Somatic symptoms are more common rather than the mood symptoms like sad, anxiety. So those symptoms are less, and pain symptoms, the bodily symptoms, are more. Depression in older adults, what else can we look for? They are more irritable, anxious, or decreased functional status. You look for these as well, of course. Recognize that the role of coexisting medical problems, cognitive deficits, multiple medication complicates the picture as well. Many assume depression as a normal part of aging, which is not so. No, it's not normal. Whom are we going to screen? Patients with commonly associated medical problems, who have adverse life events. When we know that they can go into depression, you need to screen them. Physical signs and symptoms, pain, insomnia, fatigue, and weight loss. Make sure that you screen them for depression. Screening for depression, you have geriatric depression scale. 15-point question scale. It's 92% sensitive and 89% specific. So this is really, really good scale to screen. Just ask them directly, are you depressed? So what we do in younger age group, we ask them several questionnaires, right? Excuse me. So we ask them, are you enjoying your life for the past 2 days? That's one of the first questions that you ask them. But in elderly, you directly ask them, are you depressed? Now, medications that can cause depression. Antihypertensives like beta blockers, clonidine can cause depression. Clonidine acting centrally causes depression. Anti-Parkinson medications like carbidopa, levodopa, very important. In Parkinson's patients, we are treating them with these medications, but increasing the chance of depression is one of the major adverse effects. Others are benzodiazepines, antihistamines, and barbiturates. How do we treat? We can use SSRIs, selective serotonin reuptake inhibitors, are somewhat interchangeable regarding effectiveness. Choose an SSRI based on side effect profile, drug interaction, and compliance. Citalopram and sertraline are often recommended among experts for efficacy and tolerability in elderly. So Paxil is an anticholinergic property. Cognitive behavioral therapy and interpersonal therapy is one of the main goals. In the outpatient setting, medications and brief psychotherapy have been shown to be more effective than usual care. Going on to insomnia, difficulty in initiating or maintaining sleep, that's insomnia. Not excessive daytime sleepiness. No, not excessive daytime sleepiness. What does it become if it's an excessive daytime sleepiness? That becomes narcolepsy. This is insomnia. Usually due to primary sleep disorder like sleep apnea, narcolepsy, periodic limb movement, that will cause daytime sleepiness. Most commonly due to psychiatric illness, psychosocial problem, drug alcohol dependence, and restless leg syndrome. How do we treat insomnia? Alter the environment to make it less disturbing at night. Minimize the nighttime lighting, sounds, and procedures like the labs or the vitals, and make the bed comfortable. The fewer restraints, the better. This is, we are talking in the hospital for insomnia, not to disturb the patient in perspective with lighting and the surrounding environment. Make sure the patient is active, not napping during the day, with physical therapy, family, volunteers to help them keep company. Evaluate the medication and make sure the patient's pain is well controlled. Warm milk tea, relaxing music, white sound, and massages can be helpful. Safer medication for the geriatric population include low-dose trazodone or mirtazapine. You can give these two drugs for insomnia. Okay, I think we are into the slideshow. This presentation was developed by Dr. Kavlin Young, who is a former assistant professor of internal medicine, Division of Geriatric and Palliative of Texas Health University. All right, thank you so much. I think we are end of the slide.
Thank you so much, Dr. Amna and Dr. Ashwini. If anyone has a question.
Thank you again, Dr. Mutasim, Ashwini, and Amna. This is great presentation, all of them. Thank you so much, to the point. And today also we have Dr. Ahmed Dawanur with us. So later on, when we have the mock interview, maybe we can get some input from him. Dr. Ahmed,
Sure.
do you have any addition right now, or we can wait for later?
Assalamu alaikum, Nadir,
Alaikum assalam wa rahmatullahi.
and all other doctors who are contributing to this meeting. يعني حقيقة أتشرف بوجودي بيناتكم، ويعني أشكر الأخ نادر على يعني هذه يعني المبادرات الجميلة يعني والفلوشيب. ف يعني سمعت للكلام سوري I will stop talking in English نادر. احتمال معنا ناس ما بيتكلموا عربي صح؟
Yeah, we do.
Yeah, I apologize for that. So I'm privileged to be among you here, and really I listen, and I will comment at the very end, but the presenters they present great information, and really I enjoy it. Thank you.
Thank you so much. Welcome.
Thank you so much. Now it's my turn. I'm going to present Fishbone diagram. Its definition uses advantage, disadvantage, and let me start sharing my screen. Are you able to see the screen now?
Yes.
Okay, yeah. So the Fishbone diagram, its definition, it's also called cause and effect diagram. Fishbone diagram is a visualizing tool for categorizing the potential causes of a problem in order to identify its root causes. It's a visual diagram named of its resemblance to fishbone and ribs. Fishbone analysis begin with the problem, and the fishbone provides a template to separate and categorize the causes. The main goal of the fishbone diagram is to illustrate in a graphical way the relationship between a given outcome and all of its factors that influence this outcome. The main objective of this tool are to determine the root cause of a problem, focusing on a specific issue without resorting to complaints and irrelevant discussions, identifying areas where there is a lack of data. When should a fishbone diagram be used? When we need to study a problem or issue to determine its root causes, when we want to study all the possible reasons why a process is beginning to have difficulties, problems, or breakdowns, and when we need to identify areas of data collection, and when we want to study why a process is not performing properly or producing the desired result. Field of applications focus attention on one specific issue or a problem. Focus the team on the causes, not the symptoms. Organize and display graphically the various theories about what the root causes of a problem may be. Show the relationship of various factors influencing a problem, and reveal important relationships among various variables and possible causes. And it also provides additional insight into a process behaviors. This is an example, delay of consultations. Here are the steps of Fishbone. Prerequisite to be met: identify the problem, work out the major factors involved, identify possible causes, identify specific factors, detailed levels of causes, and analyze your diagrams. Those are the steps of Fishbone diagram to analyze the causes of the problem. Step one is to identify and clearly define the outcome or effect to be analyzed, like write down the exact problem you face. Where appropriate, identify who is involved, what is the problem, what the problem is, and when and where it occurs. Everyone must clearly understand the nature of the problem and the process product being discussed. The second step is to use a chart back position so that everyone can see it. Draw the spine and create the effect box. Draw a horizontal arrow pointing to right. This is the spine. I'm going to show you the diagram. Next slide. To the right of the arrow, write a brief description of the effect or outcome which result from the process, and draw a box around the description of the effect. Here's the step 1 and 2. So it's increase time. The example is to increase time on finishing questionnaire while doing pilot study. So the main problem or the outcome is the increased time to finish questionnaire. Step 3, to identify the main causes contributing to the effect being studied, like labeling the major branches of the diagram. Establish major causes or categories under which other possible causes will be listed. Write the main categories your team has selected to the left of the effect box, some above the spine and some below. Draw a box around each category labeled and use a diagonal line to form a branch connecting the box to the spine. So this example, we identified the following factors and add these to the diagram, like material, methods, people, environment. All those are like the major categories to the problem. So we're gonna put it this way. Increase time of time to finish the questionnaire is a problem. We need to like find the causes. So we're gonna go through all the methods, materials, environment, and people to see which factors contribute to the main problem. Step 4, for each major branch, identify other specific factors which may be the cause of the effect. Identify as many causes or factors as possible and attach them as sub-branches to the major branches. Fill in detail for each cause. If a minor cause applies to more than one major cause, list under both. So this is the example. Under the material, we have like small factors, contributing factors like GDS is too long, geriatric depression scale is too long, too many questions, difficult to comprehend, similar questions like repeated question, interpretation of Likert scale is tough. Under method, we have like small factors contribute to the method, like self-administered questionnaire, language barrier, compliance with the filling questionnaires, or time consuming. Under environment, we have like rainy seasons, working hours, morning hours, due to rain or approach to houses are difficult. And under people, we have like suspicious people do not like want to answer questions asked to them, or they are not interested to answer the questionnaire, or old age, or not cooperative patients, or difficulty in understanding if there is like language barrier or cognitive impairment. So step 5 is to identify increasingly more detailed level of causes and continue organizing them under related causes or categories. You can do this by asking series of why questions. You may need to break down your diagram into smaller diagrams if like one branch has too many sub-branches. Step 6 is to analysis of the problem. You should have a diagram showing all of the possible causes to the problem that you can think of. Analysis helps you to identify the causes and warrant for further investigation. Since cause and effect diagram identify only possible causes, you may want to use a Pareto chart to help your team to determine the cause to focus on first. Depending on the complexity and importance of the problem, you can now investigate the most likely causes further. This Pareto chart, it's a graph chart. It's a bar graph. Sorry for the misspelling. The lengths of the bars represent frequency or cost like money or time, and are arranged with the longest bars to the left and the shortest bars to the right. In this way, the chart visually represents which situation are more significant. Look at the balance of your diagram, checking for comparable levels of details for most of the categories. A thick cluster of items in one area may indicate a need for further study because it might be the main cause of the major cause of the problem. Main category having only few specific causes may indicate a need for further identification of causes, and look for causes that appear repeatedly. These may represent the root cause. Same diagram here. This like another example of the fishbone. The major problem is inadequate HIV screening among primary care intermedicine providers. We have the major contributor to the problem like place, patients, providers, or policies. Under place, we have like no current EMR reminder for HIV screening. Prevalence of HIV in like Rochester not as high as the larger cities. Under providers like unfamiliar with screening guidelines, assume that the patient are low risk and so do not need a screen, uncomfortable with discussion, and or do not remember to talk about HIV with HIV screening with the patients. Under policies, we have like opt-out HIV screening and post-screening counseling policies not clear, or there is not a specific policy regarding HIV screening like at MEA. Another example, like poor quality of care, we have to identify like the major contributors, people, process, policy, or equipment or supplies, and environment. Under people, like the causes might be like poor role identification among healthcare workers, insufficient staffing facilities. Sorry, this is under equipment, I think. Inadequate education, knowledge, and skills among facility-based health workers, and equipment or supplies like insufficient medicines. Current facilities are inadequate to meet the demand. Contributors to the environment like limited opportunities for education or too few facilities available. And the process and policy, like lack of coordination between different levels of health facilities, poor or no referral system, overcrowding in emergency department. All those are contributors to the main problem, which is poor quality of care. The advantage of Fishbone diagram, it helps determine the root causes, encourage group participation, use an orderly, easy to read format diagram of cause and effect relationships, indicates possible causes of variation, increases knowledge of the process by helping everyone to learn more about the factors at work and how they relate. Disadvantage, like they create a divergent approach to problem solving, where the team extends a great deal of energy speculating about potential causes, many of which have no significant effect on the problem. This approach can leave a team feeling like frustrated and hopeless. They are typically based on opinion rather than evidence. The simplicity of the Fishbone diagram can be both its strengths and its weakness. As a weakness, the simplicity of the Fishbone diagram makes it difficult to represent the truly interrelated nature of a problem and causes in every complex situation. Extremely large space required to draw, like when the causes are, when we do have like many causes. Conclusions, Fishbone analysis provides a template to separate and categorize possible causes of a problem by allowing the team to focus on content of the problem rather than history. It's useful in root cause analysis, which is increasingly being used in health services to improve safety and care quality. It's a successful way of using fishbone analysis to encourage a group of staff who are involved with a series of or clinical pathway to work together to identify all possible causes of a problem. On completing this exercise, the solution will likely be identified and the action plan for the next steps can be drawn up. Thank you so much. This is all about the fishbone diagram, and here are the references I used on my presentation. Thank you so much.
Excellent, Dr. Sulafa. Thank you so much. This is also excellent, great presentation and concise to the point. And we use it in the medical field, and they use it in other fields as well, in factories, in other companies, to assess and evaluate, categorize, and find solution for certain problems. Excellent, good work. Actually, in 2 days, we're gonna be the deadline for the Amna. And speaking about that, I'm gonna share you this poster, for example, using the fish diagram on one of the posters that was submitted to one of the conferences regarding the fall prevention. And we can use that in, let's say, for nursing home setting or assisted living setting to assess older patients when they had a fall, what are the causes, and then they went over some of the causes in this poster and identify some of the solution and what can be done as prevention in the future. So thank you so much for presenting this important topic.
You're welcome, Dr. Nadir. Now, last but not least, we have mock interview, Dr. Duaa and Dr. Areej. If you are ready, you can start.
Yes, hello everyone.
Hello. So we're gonna start our little mock interview. Duaa, please tell me about yourself.
Hello, Dr. Shafia. Thank you so much for having me here. I'm so happy to be here. My name is Duaa. I'm originally from Sudan, but I was born and raised in Saudi Arabia. I went to Sudan for high school and then my medical school, and there I developed a passion for volunteering. And that's why I created a student association with my colleagues to volunteer and raise the awareness in the society. And afterwards, I also volunteered with Sudan Sepsis Alliance and Sudan Stroke Society. Away from medicine, I love basketball. I love being an athlete. I was captain of a women's basketball team in Sudan. And I was also chosen to play for the national team in Sudan. I enjoy running, weightlifting. I enjoy martial arts and also reading books. So this is.
Wow. Okay. So why did you become a doctor then?
So being raised in Saudi Arabia, I was raised in a compound where only doctors live there, as my dad is a doctor. And me and my friends used to do a lot of custom parties, and every party I was always the doctor. And then I used to go to Sudan with my dad, and I used to see, like, visiting our village, used to see my dad seeing a lot of patients and treating them for free. And this is the main reason why I became a doctor, and I have the passion for volunteering. So it has everything to do with my father.
Wow. Okay. Okay. So please tell me why neurology?
My passion for neurology started when I was in high school and being fascinated with the brain and the nervous system. And then when I went into medical school, I had this professor who was very passionate about neurology and used to imitate every gait perfectly. He's one of the reasons why I got attracted more to neurology. During my internship, I found the diseases of the neurology is very, very challenging. And being an analytical person, from the first question of where is the lesion, I found myself very passionate about this specialty. And I pursued applying for neurology residency in the United States because of the advances neurology has made here and because of the variety of subspecialties it has here in the States. And the advances of mechanical thrombectomies and deep nerve stimulations. And this is why I specifically applied for your program, because to get exposed to these advances and the variety of subspecialties.
Okay, then where do you see yourself in 5 years?
For me, I'm focused now on being on learning a lot about neurology and being a competent resident. And after finishing residency, I'm going to pursue a fellowship in neurology. For now, I'm a little biased to neurocritical care, but that's because I got more exposed to this field. But I'm open to all the subspecialties and willing to see where my passion leads.
Okay, then why are you applying to this specific program?
Your program connects to me on a personal level. As you know, my brother is in your program and he speaks very highly of it. It's very important for me to be in the same city as my brother to support each other here. Also, your program is the main referral hospital for neurological cases here in Wisconsin, and this means that I'm going to get exposed to a lot of diversity of cases. And I love your program's learning structure and the variety of subspecialties you have. And that's why I want to get exposed to these subspecialties.
Okay, then please tell us, why should we pick you?
I'm sure everyone who interviewed with you is qualified enough for this residency position, but being born and raised in Saudi Arabia and then going to Sudan, this makes me, I'll be able to bring different cultures to your program. And also being working in Sudan with limited resources has made me learn a lot about the importance of being a good clinician, and depending on my history and examination, as a lot of patients cannot afford many investigations and a lot of investigations were not available. For this reason, I have good clinical skills, and I'm sure this is important in a resident. I also have great leadership skills, and this comes from my the association that I created with my colleagues, and also being captain of a women's team has made me learn a lot about being a leader and the importance of the ladder in the leadership. I'm also a very social person and I'm very easygoing. I came to the States just 3 months ago and I already made friends here. And I'm sure this is an important quality in a resident in your program.
Okay, could you just tell me a little bit about any weaknesses that you have?
One weakness that I have is being emotionally attached to my patients. This happened specifically during COVID-19 when I volunteered in one of the isolation centers in Sudan. And of course, I lost a lot of my patients, and it made me feel, it drained me mentally and it made me feel sad most of the times. I try to be more aware of it, and I try to learn a lot about emotional intelligence and to be empathic towards my patient, but not to be emotionally involved. And it's improving, thankfully.
That's good to hear. Okay, lastly, can you tell me, how would you handle a conflict with a colleague?
I'm sure in residency and in any working, in any job, conflict is inevitable and it's bound to happen. But my main goal is in a conflict is the resolution of this conflict. So I'm going to initiate an informal communication with my colleague, and I'm going to invite him for discussion of the conflict, and I'm sure that we can work something out without involving other people and the resolution of this conflict.
Well, thank you so much, and best of luck.
Thank you so much, Dr. Shafir. I'm so happy to be here.
Thank you so much, Dr. Duaa and Dr. Areej. Dr. Nadir, if you have
Thank you both.
Thank you.
Yeah, thank you. Thank you both. This is great. Also, mock interview. Thank you, Dr. Duaa. So the camera angle, the lighting, everything looks great and excellent. You used your body language explaining things, your answers to the point, and I think they are concise and excellent answers. I don't have any negative feedback. I think you can elaborate a little bit. There is always room for improvement. So the last question, for example, you answered very good, but if you want to highlight, and sometimes key words here, what really sometimes the program director may need to hear is patient care. So when you talk about conflict, yes, it's between you and another resident. If you inject or you just insert the word and my goal or overall or my ultimate goal is to confirm or to make sure the high quality of care is given to the patient. Something along this line that makes you a better understanding of why they ask this question. Yes, they want you to be a team leader as well as a team player working together. But the goal out of the residency is to give a good care to your patients. So I like all your answers. Thank you so much.
Thank you so much. Thank you, Dr. Nader.
Dr. Ahmed, if you have any comments, please.
Hello, everybody. Really, it is great interview. Both the interviewer and interview did great. And if you look at the interviews for residency and you just think about the top 50 questions, and the first one is tell us a little bit about yourself, and you hit that thing. So this is great. And my advice is take the thing holistically. Try to think as a bigger scale. And when you came, don't come with the ready answers. Try to be creative and also try to think about what you are trying to say. This is very important. And the other thing is that when you speak about yourself, try to make the points. What I mean is, if you are a team player, hard worker, knowledgeable, don't try to say it directly. What you say tell the interviewers about if you are a team player, knowledgeable, or you are a leader. The interviewee, the last one, she did very well. She did great. And one of the thing I would like to emphasize is like ready answers. Try to, as I said earlier, imagine if they ask you tell us about the case that is very interesting to you. They want to test your knowledge. So in that situation, try to really mention something that impressed them. For example, I will give you an example. Things sometimes are very clear when you talk about the example. For example, if you are applying for pediatric and you want to just make a presentation about the case, and this case say it is a sickle cell anemia. You tell them about the case and you come to the management. So in the management, and actually, as you said, and the previous presenter, I attend this meeting from the beginning, they talk about the history, physical exam, and then they come to treatment. So for example, sickle cell anemia, you talk about the treatment and you said the word hydration. And here they know that you know your topic even at cellular and molecular level, because in sickle cell anemia, you are hydrating your patient. This is simple, but it tells us that you know the pathophysiology. I want you to be at that level. For example, the one who talk about pancreatic cancer initially, they talk about tyrosine kinase inhibitors. How you impress your interviewers about how knowledgeable you are. You said our patient responded to treatment, and in the first few days, his blood pressure start to go up. So hypertension is a side effect of tyrosine kinase inhibitor, and this tells them that you know well about the clinical pharmacology, the pharmacokinetics and dynamics and pharmacogenomics of your the medication or the toxins you are throwing on your patients. So I want you to be at this level. And also the leadership is a very good quality that you need to know. And the other thing is that, yes, you are knowledgeable, you have a high USMLE scores, and you are ready to be a team player. But what about the other quality, especially if you are applying to academic program? Then you talk about the research experience, either overseas or here in the United States, or the experience you are doing in this fellowship. About the research, if you did clinical research, talk about research in general and show your interest in all spectrum of research, because this is how we generate knowledge. You say, I'm interested in basic, translational, and clinical research. I have a great chance that I'm a part of a clinical research, and this is what I have done. So I want you to be like, to look at things in a bigger scale, but when you come to impress them at a specific thing, you have to tell them in an indirect way sometimes, especially like when you say, I'm knowledgeable, I'm a team player, it seems that like there is some arrogance, but if you explain it in another way, that will that will be better. And a lot has to be said about interview, and really like one time is not enough, and always try to rehearse and try to be yourself and try to be real when you go for interview. So once again, the mock we have seen is really great. And why is that? Because they ask about medicine in general, why you choose medicine, then the specialty, then this program. So it shows how excellent this interview was. And thank you.
Thank you so much, Dr. Ahmed. That was very helpful.
Thank you.
Thank you. Thank you, Dr.
Thank you
Ahmed.
so
And,
much.
Thank you, Nadir.
yeah, I like the energy, Duaa. So that's also an important aspect. We don't talk about it much or a lot, but the energy when you show them that you are enthusiastic and you are interested in their team and their program and so forth. So, and as Dr. Ahmed mentioned, focus also if it's an academic program on how you did as far as research. My team and I presented this, or we are writing this, or we are working on these 2 projects. You don't have to give the details, just give them a bit where they can, if they are interested, tell them more. So you will say, I worked on this project with my team and it's going well. So they may ask you, well, tell us more about this project. Then you will give them some more information, something like that, if you want to. But in all, you did great. Thanks.
Great,
Yes.
thank you.
Can I mention one thing, please, Nadir?
Yes, go ahead.
Yeah, the other thing is that the one of the last question is a tricky one. Tell us about your weaknesses. So there is some word, don't mention it. Like don't repeat the word my weakness. This is one. The other thing is that don't mention a strong word like sad, emotional. That is how I look at it. Try to work this tricky question around, like the inner viewer mentioned a very important thing is that her passion, like the weakness is her, she's very passionate, if I mention it right, and correct me if I'm wrong, that she is emotionally attached to her patient. And that is a good thing, but avoid saying sad or any word like that. And try to work around this question by just broadly mention that, for example, if you stay late, say, I like my work, and sometimes I even concentrate more about my work, about my colleague, about the program in general. Make the weakness as your strength, but don't mention the word weakness or any other word that could point to a real problem. But overall, what have been said is really very good. Thank you.
Okay, thank you.
Go
Thank
ahead.
you so
To
much.
add to that, can I just interact and interject? One example? Usually, I tell my my trainee that if you want to, you can just use the word. And there is always room for improvement. So instead of, as Dr. Ahmed mentioned, don't say my weakness, you can laugh about the question and say, there is always, every one of us has room for improvement. And then you can start talking about whatever area you work on. And I like your example because you ended up with solution or working on to improve. So that's great. Thank you.
Absolutely.
Yeah. Go ahead.
Thank you
I think
so much.
So much.
Thank you. Thank you so much, Dr. Duaa, Areej, and thank you so much, Dr.
I
Ahmed,
think
for
Dr.
sharing.
Rafda has a feedback.
Yes, hi, Duaa. Really, you did a great job. My only
Thank you
comment
so
is,
much.
I was distracted with your hands movement because your hand was really close to the camera. So I would rather if you had your laptop a bit higher, you can put like books
Okay.
under it, so it can be at the level of your eyebrow. And then when we see your hand, we wouldn't see your hand as like really as close as it was. Other than that, you really did a good job, and I can tell that you were nervous, but you did a great job.
I was. Yeah. Thank you so much, Dr. Rafda.
Thank you, Dr. Ahmed, for sparing time to be with us and for your valuable guidance. Now it's time for projects. If anyone has
any updates, if anyone has, I think Dr. Sulafa, the other one, she is going to present Monday in 2 days in NAPGREC, the conference about our fellowship. So we'll see how it goes. And in the coming 2 days, I think there are a couple of abstracts we are submitting to Amna. So the deadline is on Monday, end of Monday. So if you have any things, let me know or email, shoot me a text or call me. Any other updates? Yes.
Yes, Dr. Nader, we are submitting our abstract, the one about the misdiagnosis of MF for the past 13 years. They have the character limit at 3,000. We decrease all the words. We cannot include the reference, and there is no section to include the reference. So is it okay to submit it without the reference part?
Yes.
Okay.
You can do that.
All right, that's all. Thank you.
Excellent.
Nader.
Yes, Dr. Ahmed, go ahead.
I like your background.
Oh, thank you. Thanks.
Yeah, I
So-
agree. It's beautiful.
Oh, thank you. Thank you. So for Duaa, one more, and for other fellows who are going to do interviews, expect some silly questions. Sometimes they may ask you, tell me more, if you were, let's say, an elephant, which one you want to pick, elephant, rabbit, or lion, something like that, and why? Some may ask you, what's your favorite book that you read, or tell me more about a movie that you watch that stick to your mind. If you are applying to neurology, I'd advise to watch the movie Awakening. It's a good movie. There is another one about a man who mistaken his wife for a hat. So these are two, I think, movies that might be interested in neurology. It has aspects. So thank you so much.
Great. Actually, some other people also got the question, one of the silly questions of what ice cream flavor would you like to be? So this is one of the questions my colleagues had.
We cannot hear you, Dr. Nader, if you are speaking.
Dr. Nader is mute.
One of my friends, she got a question about, because she's an old graduate, like most of us. They asked her, are you good? You know that your senior going to be younger than you, so are you teachable? So that was a tricky question.
Would you repeat the question one more time, Dr. Ragna? What was that again?
Since you are an old graduate, your senior will be younger than you. So are you teachable?
Thank you.
Hi, everyone. I was asked a similar question in my interview last year. Since I'm an older graduate, they'd asked me if I was okay with taking orders from people who are younger than me, and how I would, how I would, behave in such a situation.
Same concept.
If you're comfortable, would you share your answer with us, if it's okay with you?
So I had just, I don't exactly remember what I had said, but I had said something on these lines. I had said that, I'm very teachable. I'm a fast learner, and I'm adaptable. I can work with anybody, and I will take feedback from anyone, irrespective of their age. And I'm here to learn, whether it's from my colleagues, my attendings, or my patients. And that's something, I said something on these lines, and I told them that I'm a team player. Yeah. So I just basically mentioned that age doesn't matter, and that I would be willing to learn and grow. Yeah, I ended it. I remember saying that I'm there to grow and learn as much as possible from my residency to become the best psychiatrist that I can be. Yeah.
Good answer.
Hope it helps.
Thank you, Dr. Shushma, for sharing this.
Yeah, and I also wanted to share my interview experience from this time. So my interview was last week, and I think it went well. So things that I think worked in my favor were, I was very calm. I showed energy and I showed passion, and I was like smiling throughout. So I got feedback from resident I knew there that they actually noticed. I had interviewed in the same program last year. So yeah, I got feedback saying they actually noticed the change in me, and they noticed how I had I sounded more positive and more passionate than last year. So, and the interviewers actually like remembered me. So the first question I got was not tell me about yourself. They said, we already know you. So tell us what you've been doing since you didn't match. So I basically just had to like share whatever I was doing in the past 1 year. And then they asked me about a challenging experience that I have faced in my life and what I really learned from that experience and how I would use that towards patient care. And another interesting question I got was, I had already mentioned my hobbies. So they asked me, what I would do to de-stress, or, to basically after a long day in the hospital, or when I have a challenging or a difficult patient, how would I handle that and what would I do to de-stress? So yeah, these were some of the unique questions that they asked me.
Thank you so much, Dr. Shishma, for sharing this. Good luck.
Thank you.
Anyone want to share something?
Your experience. Would you mind sharing your answers? Because I like your answers, if you don't mind. Thank you.
Which question are you talking about?
What do you do for relaxation? Like to de-stress?
Sure.
Right.
Sure. So I initially I'm a Vipassana trainee. So I'm a Vipassana trained meditator. So I just told them that I meditate every day. I take time to do some mindfulness exercises. But I told them, like, if when I'm faced with a challenging situation or a challenging patient, I would just just try to understand the situation, take a few minutes to gather myself, to take a few deep breaths, and and then I will try to like weigh everything in my head and come back feeling a little fresher and calmer, better, and so I'm better able to handle the situation. So basically the point you need to make is you'll take a few minutes a small break, and you'll either like do breathing, mindfulness, or some people will like drink some water, or listen to some music, something like that. So just have to like basically tell them how you'll cope with that situation. So just some coping skills is what they're looking for, I think.
Very nice. So much.
Yeah. And yeah, of course, I also told them that I love to cook. So I told them that, cooking relaxes me. It helps me de-stress. So after a long day at work, that is what I would, love to do. Cook something cook something healthy for my family and for me. So, we are all, so it helps me relax, and at the same time, we are all, fed and, fed healthy food, something like that. I said, I'm sorry, I'm not remembering the exact things that I said, but like Dr. Ahmed said, I didn't really prepare the content. When I was preparing, I was preparing more points in my head, so it sounded more more extempore. Otherwise, when we prepare too much, we sound extremely monotonous. And I had been doing that in the previous years, and I could like make out when I was telling my answers that I was sounding robotic. So this time I went more with just points, and I just spoke, on the go. Yeah. So yeah, thank you, Dr. Ahmed, for all your advice. They're really, really helpful.
Thank you.
Dr. Shushma, they ask you about what did you do since last year? How did you answer this question? If you want to share that with us, thank you.
Sure, Dr. Nadir. So first I started off with, yes, it was very unfortunate that I did not match. And then I told them about the clinical experience that I've gained, and the research that the research group that I'm working on. Like I spoke about this group, and I'm a part of a few other research groups. So I mentioned that, and I told them all the papers I've published. And I at the same time told them that I've been doing a course in psychotherapy. So I told them how I'm doing that to acquire skills in psychotherapy. And I mentioned about leading teams or projects. So all the papers that I led and how we worked on and how we handled everything. And I ended it by saying that all these skills have better prepared me to handle the rigors of residency. Yeah, and I'm really looking forward to to working in. I'm really looking forward to joining and learning in your program. That's how I said, I think.
Excellent. That's good. Excellent. Thank you for sharing. So they are looking for how you improve yourself, guys. If you applied last year, what did you do to improve your skills, your knowledge, your experience, so that you can be fit and competitive to their programs. I wish you all the best. Thank you.
Thank you, Dr. Nadir.
Thanks for sharing.
Yeah, and I also have one more thing. I would say, everyone, it would be good if you guys have an answer for something that you people led to show that you're a leader, and how you handled time frames, and if you had short time frames, or if you had tight deadlines, how did you handle that? So they're looking for people who are basically because residency is very hectic, so they want to see how we would handle tight deadlines, and how we would multitask. So just have one answer ready for that. It would really help.
I do agree. Thank you so much for sharing all these important tips.
I have
Thank
a
you, Dr.
question,
Nadir.
Dr. Nadir.
Yes, dear. Go ahead, Dr. Ashwini.
Yeah, so how can we positively talk about being a medical assistant? Like as Shushma said, she received this question, what have you been doing since the last year? So how best can we talk about being a medical assistant? Because I'm asking this question because it's not a clinical experience. It's just, to get to work in the healthcare system. So how best can we represent that answer?
So basically, I would put it in a way that you were trained, you have experiences outside the US. And when you came here, you want to know the culture, you want to know the system. And the best way to do that is to get involved. And the easiest way or the best way you found in your situation is to work in this position. And your plan is to work your way up so that you can learn more about the system, the EMR, how to handle patient situations, social aspects, all these kind of things. And by doing these jobs, you can learn a lot, and it will help you in your experience, skills, and knowledge. If that makes sense.
Yes, it does. That's right. Yeah. Thank you so much, Dr. Nadir.
You're welcome. And if you want to always try to incorporate the culture, so you came from a different culture and you are going to incorporate your skills to improve and learn about this culture. So it's kind of not only medical. You want to personalize things and add some aspects. Excellent.
So if one of the patients really appreciated the communication skills, like the patient clearly writes, I like this medical. So is it a nice thing to say to your interviewer?
Definitely. So that way you will show your skills, your communication skills, and also feedback from the patient. So you will mention the culture, and you can say, and by the way, I improved my clinical and communication skills. And in fact, when patient said so and so and so, so you can incorporate that. Yeah, definitely.
All right. Thank you, Dr. Nader.
You're welcome. Excellent. Good luck. Good question. Any other questions or comments or addition tips?
Yes, Dr. Nader, how to answer the question about what is your greatest achievement?
Excellent question. So it depends. Every one of us have different goals or passion about different things that they work hard to get into. So whichever you think your goal that you achieved might be of interest to you and you work hard, you can mention it. So you can say, yeah, that's a great question. And one of the things that I love to do is so and so. And in fact, my goal was to achieve this, and I worked hard. I learned the basics and advanced my skills. And by that time I finished whatever the goal, I reached that goal. Sometimes you can mention if like Duaa, she said she worked and she has the leadership, she established the women organization, and I worked with martial arts. In fact, I reached the black belt or whatever belt, and this is the top of that class or something like that. So you can mention whatever you think is of interest to you and how hard you worked, and you can mention that you achieved the goal. So you set the goal, you work hard, and you reach there. If I answered your question right.
Yes, my prepared answer for those questions, although it's so generic, but I couldn't find something to say, but I can tell you about it and you can tell me about your insight. Like I would say, as an international medical graduate who passed all the United States medical license examination, including a step 3 at the first attempt, and being here interviewing with you, these are my greatest achievement toward my career.
Sounds good. I think that's a great answer. There is nothing wrong with that. If you want to add more, then you can add more. If you have other aspects in your life that you think you have achieved, so you can add to that. If you don't have anything in mind, think about it. If not, then this is a great answer.
Yeah, right. Thank you, Dr. Nader.
You're welcome. Good question. Any other questions or comments?
I just want to add something, Nader.
Yes, go ahead, please.
Yes,
Thank you.
yes, and about the achievement. You are a physician and you have been called for the interviews, so you have achieved a lot. And don't make it only about medicine. So you have, as another hint towards social life, other things in life you have achieved. You can mention it, like volunteering. Okay, those who establish other things in life, like groups, associations, those who run other organizations. So this is great achievement, and it tells your excellence not only in medicine, but in other skills like multitasking, as you mentioned earlier, and your team playing characteristic and other things. So try to be open and try to go out of the field of medicine when circumstances permits. So so try to and when they ask you about the greatest achievement, you can say, I was lucky, I have achieved this and this, but I feel this is the most. You can say that. So they will know that you did a lot. About the USMLE example is an excellent one, but we know that you are excellent. You did well in your USMLE exams, and that is why you are here, and that is why we are interviewing you. Okay. But and I'm sure, like for example, my generation, including Nadir. We are on the same path. So one of the achievements is to join the Faculty of Medicine from when you score high in the high school. That is one thing, and then you graduate, and as you say, USMLE. But there is other things a lot you have achieved, like you have done a lot. So try to be open, prepare yourself, and there is many questions that are going to be asked. You might not be prepared, but just take your time, smile, and answer the question. You will do well. Thank you.
Thank you, Dr. Ahmed. Honestly, my biggest problem is that I speak in fast pace. And especially when I'm anxious, I speak like someone is like, there is a dog behind me. So besides this, I know about the cultural difference between the US and Sudan. So I don't want to say something as a great achievement. And here in US, they see it as something normal, like everyone do it.
Yes, I'm gonna just comment about this.
Yeah, sure.
So when you ask a question, the first step is to understand that question. Be yourself. If you speak fast, that is not a problem, but make sure that other understands you. Okay, that is the most important thing. For example, you can rehearse, okay, and you can practice with your colleagues. The most important thing before you go to interview, to write to talk to a friend as a physician colleague. And the mark we have been doing here is great thing. For example, those who took the, I just try to give an example, and then you can just, you will feel comfortable about the way you talk. And for example, those who take the clinical skill assessment exam, you will ask, for example, someone comes with a chest pain and he talked to you about his chest pain. And you will ask about the 6 characteristic of pain. And it could be chest pain, it could be headache. So the intensity, the location, the radiation, association, factors, and others. And when you come to the intensity, he will tell you 10. Okay, so 10. And in that situation, you talk, if you are a fast talker, be sure that you will just think around and what I'm going to say. Am I going to jump to the next question? No, you are going to see what I'm going to do. So 10, oh, I have to show empathy here. Oh, sorry, this is severe. We are going to do this and this. Okay, so anything, even if you are talk fast, okay, if you answer everything right, that can adjust the whole thing. But the most important thing is if you talk fast and you miss something, then they say, oh, could be because he's talking fast. So the things are taken collectively. It is not only one thing. And when you come well prepared, you will do it. And the interviewing process is really simple. It's not that difficult. Okay. And the practice I have seen here is really great. If you do it once or twice, you will nail it. Okay. And when you being interviewed in a programs, there are many people who are being interviewed. So if you are not much in this program, it's not because you are not an excellent candidate. You are. The only thing is that there are many. And also remember, in some programs, you are being matched because of many other things. Your experience, your research, your publishing, and even your connections. Okay, so remember, it is a big thing and not only one thing. Thank you.
Thank you, Dr. Ahmed. Thank you so much.
Thank you, Dr. Ahmed. And also, I want to mention 2 things for this question. You can start with some background. For example, you can say, as a mom, if you're a mom with whatever kids, I work hard. That means you are responsible for your family. On top of that, you work hard to achieve whatever things that you are trying to achieve and you already succeeded. The other part of the question is use keywords or highlighting words to explain things and to use them showing your characteristics. So I was persistent, or I was, as we mentioned, team leader, or something that to show your qualities. You can try to add these qualities in any answer, and then you can elaborate if they ask you some details. But in general, that's good. Good. Thank you so much. Good luck, everyone. Good luck. Thank you. If no more questions or comments, we can move to the next section.
Thank you. This is all, Dr. Nadir, all the topics presented.
Sounds good.
If you
So
have...
for the last part, I think we can just work on planning for next meeting. Hopefully this is the agenda for the blue team. If the team members are ready, please document or confirm your participation. If you are busy, please try to reach out to the team leader and let me know if you have questions. Really, I appreciate your time and effort, and thank you so much for great presentations today. Thank you all the presenters. Thank you, Dr. Sulafa.
Nadir, one
thank
thing.
you, Dr. Ahmed. Yes,
Yeah.
Go ahead, Ahmed. Yes.
Yes, just have you presented recently something about hypertension?
We have done some down a few months ago, but not recent.
Okay. So yes, if you are considering that, or any one of our colleagues here want to do that presentation, just I can be in touch with him or her.
Sounds good. So
that is a good copy, especially in elderly. Yeah.
Yes.
Yeah.
So we will put that in the coming agendas, maybe in a couple of weeks or so. Thank you so much, Dr. Ahmed, for your time. And,
thank you.
Yeah, this is great to have you, and thank you for your input.
Thank you.
Thank you, everyone. Yeah, go ahead.
Yes, I want to thank everyone, and see you next week, inshallah.
Inshallah. Assalamu alaikum. See you next week.
Thank you, everyone.
Thank you.
Thank you, Dr.
Thank you,
Nadir.
Dr. Ahmed.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir.
Thank you.
Thank you, Dr. Nadir, for everything that you did for us, for your effort, for your time, for everything. Thank you.
Thank you, Dr. Nadir and Dr. Ahmed. We appreciate your time today.
Thank you
so much.
Thank you, Dr. Ahmed. Thank you so much, Dr. Nadir, for all the suggestions. Thank you so much.
Thank you,
everyone.
Thank you, Dr. Nadir. Thank you, everyone.
Thank you so much, Dr. Nadir. Thank you, Dr. Ahmed.
Thank you.
Thanks a lot.
السلام عليكم. كتر خيركم.
السلام.
Thank you, Dr. Ahmed. See you.
Thank you.
Thank you.
Thank you.